High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I am your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts, hear stories from the emergency department, and listen to people who have struggled from addiction. Friends, fentanyl is plaguing America. It has infected all illicit drugs, from cocaine to meth, counterfeit pills, and even marijuana. If you're around someone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. If you need a prescription for naloxone, you should have one. No questions asked. That is why I am offering a free prescription to anyone who needs one. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. And if you like the show, do me a favor. Give us a 5-star review and subscribe. Your stars are very much appreciated and go a long way in supporting the program. Today's episode is sponsored by ISAAC, the International Academy on the Science and Impact of Cannabis. Visit their website, isaac1.org, IASIC1.org, to follow the science on marijuana. Hello, High Truth listeners. Get ready for a settling episode. I'm your host, Dr. Ronit Lev. The United States has seen high-dollar financial lawsuit settlements from industries who lied about health. Worldwide, tobacco use causes more than 7 million deaths a year, according to the World Health Organizations. And in 1998, state governments were awarded $246 billion in lawsuit tobacco money for that damage. That's a lot of money. But does that make up for the cost in loss of life? We know that states awarded tobacco money used it on initiatives that had nothing to do with tobacco or mitigating tobacco damage. Now fast forward from tobacco to opioids. Today, we're experiencing more than 100,000 overdose deaths a year, with the majority from opioids. Big pharma companies will be paying over $32 billion for lying about harms of chronic and high-dose prescription opioids that killed people. Will that money be spent on saving lives? Are lawsuits a deterrent for future public health lies, or is lying about public health a good business model? Is big marijuana following in the footsteps of big tobacco and big pharma in lying and hiding public health risks? In the meantime, what is the best use of opioid settlement dollars to make sure that that money is spent on saving lives? Lots of unanswered questions. And with that, let's hear our question of the day.
Hi, Dr. Lev. Thank you for your advocacy and education. I'm especially thankful for giving voice to parents like me whose children died because of cannabis. My name is Michelle Leopold, and my son Trevor died chasing a higher high after becoming addicted to today's high-potency THC. He thought he was taking a blue 30, but the oxycodone pill instead contained a lethal amount of the powerful opiate fentanyl. He will forever be 18 years old. States and counties are getting large sums of money from lawsuits against opioid pharma companies. Just this morning, seeing the newspaper headlines, my husband and I wondered, how do we make sure these dollars go for drug treatment and prevention and not squandered on other projects like what happened with tobacco? Thank you.
Thank you, Michelle. I have a great expert to answer your question, Sara Whaley. Sara is a research faculty at the Johns Hopkins Bloomberg School of Public Health and is the program manager of the Bloomberg Overdose Prevention Initiative. She works on coordinating efforts that make sure opioid litigation dollars are distributed fairly and effectively. And you can find Sara Whaley's bio on the High Truth show notes. Sara, welcome to High Truths.
Thanks so much for having me. I'm excited to be here.
And I'm excited to have you as well. So let our High Truth listeners know a little bit about yourself. How did you become involved in the issue of opioid settlement dollars?
That is a great question, and one I actually ask myself often. How did I get involved in this? Because I'm not a lawyer. My background is in social work. I used to do direct service, and I worked briefly with a county government. Then I got involved in public health research, specifically with people who use drugs in Baltimore. And that's how I really got involved in advocacy. I started a role with Johns Hopkins at the Bloomberg School of Public Health, working on a project called the Bloomberg Overdose Prevention Initiative. And it was in this providing research and technical support to state governments that we started to get asked the question of how states should spend their opioid litigation dollars. And that's how I got involved. That's how I started.
Interesting. So tell us about this initiative, the Opioid Prevention Initiative.
Yeah, so we are funded by Bloomberg Philanthropies. We work in conjunction with a few other organizations in 7 states across the country. So our sole mission is to save lives from overdose, and we do that in a variety of ways. Our team at Hopkins provides research support, so evaluating programs and policies in states, and then we also provide technical assistance.
Interesting. Is the Pew Foundation part of that? Because I know that they've done some great work.
Yep, we work with the Pew Charitable Trust, Vital Strategies, the CDC and CDC Foundation, and then the Global Health Advocacy Incubator.
All right, so some high-powered people working on the issues of opioids. So give us a little background. All of a sudden, there were some lawsuits. There's a lot of money going around. Can you give us a little bit of the history about that? How much money? Who gets it?
Yeah. So when we talk about the opioid settlements, we're actually talking about the litigation. It's over 3,000 different lawsuits brought by states, cities, counties, and municipalities, and also tribes against the opioid manufacturers, distributors, and retailers. In the late 90s, we saw a lot of information about the misleading marketing and sales strategies of prescription opioids to the public. The first lawsuit was filed in around the late 90s against Purdue Pharma for their role. In the 2000s, more cities and states started to sign on. One example is Kentucky. They filed a lawsuit around the predatory sales of prescription opioids in Appalachia. By the late 2010s, more states were suing Purdue Pharma. There were cases against the pharmacies, and that's when the distributors and other manufacturers came about. Now, what we hear most often when we talk about the litigation is the MDL, or the multi-district litigation, which is all of this lawsuits being brought together to help streamline the settlements. So the MDL is going to result in around $26 billion. And then collectively, all of the lawsuits will see around $32 billion that's coming down to states, cities, counties, and municipalities.
That's a lot of money. But if we compare it to tobacco settlement, it's not that much money, right?
Exactly. Yep. Yeah. The tobacco settlements were $246 billion over 25 years, and we're seeing about $32 billion over 18 years. So just a fraction of that.
So Michelle Leopold is a mom, an advocate, and unfortunately, her son Trevor died from a counterfeit OxyContin pill. It's also known as a blue M30. And the pill actually has no oxycodone on it. It just has fentanyl, and he died instantly. So she asks, hi, Truth, and I'm asking you on her behalf, how do we make sure that the beneficiaries of the opioid dollars are spending money on drug prevention and treatment and not squandering it on pet projects like what happened with tobacco?
Yeah, so to give a little bit of context to that, with the tobacco litigation, the money went straight into most states' general fund. So the dollars could go to anything, and it didn't necessarily go to tobacco cessation or prevention programs. And that's something that when we started to think about the opioid litigation, that we didn't want that to happen again. And so the team at Johns Hopkins, along with our partners, coordinated the principles for the use of funds from the opioid litigation to give states and localities a framework and a foundation to make sure that the dollars were used correctly.
And how is that working out?
So far, it's been, I think I'm surprised by how well it's going. We have seen the principles used to help create legislation. So when we started this project maybe a year and a half ago, only a handful of states had passed legislation creating like a dedicated fund that the dollars went into rather than going into the general fund. Now I can excitedly say that a lot of states, and I would say most of them, have some kind of legislation or formal agreement creating a fund that protects the dollars.
So the one good thing that I saw happen from tobacco settlement is the Truth Initiative. There is money going to primary prevention of tobacco use, and that was very successful. We had less people smoking because of that. Is there something along that line, in going generally to prevent substance use disorders in this settlement?
So not explicitly. The dollars are being handed down to states and then to localities. And there's not explicit direction on like this chunk needs to go to prevention. There's a list called Exhibit E in the settlement that has some approved uses. I think there's 9 approved uses, or core strategies is the other term that they use. And it outlines different approved uses. So it includes prevention, but doesn't explicitly say that this amount has to go towards that.
That's too bad, because if there was like a national collective movement where the whole nation was on the same page in prevention, I think that would go along.
Yeah, the Truth Initiative did a lot of really great work. Yeah.
So tell us about what is approved to be spent. What are some of those 9 things?
Yeah, so there's a great resource on our website. I'm just going to do a quick plug for our website, opioidprinciples.jhsph.edu. And we kind of break down those approved uses. So the first one is naloxone expansion. So expanding access to naloxone. There's a variety of ways to do that. So getting it to, people who use drugs, people who have contact with people who use drugs. So that can be family members, first responders, police, other community members. So that's the first one. There's also ones around prevention, improving access to treatment in carceral settings, providing treatment to pregnant and parenting people. Let's see, there's more. Expanding warm handoff programs. It's a pretty extensive list and hits kind of in all of the different areas on the spectrum of opioid use.
Peer support.
Peer support is on there. Harm reduction is on there. It's pretty encompassing, yeah.
And so you created principles, right? And you have a coalition of people who created these principles of how to spend the money. Maybe just give us a little breakthrough of what those principles are, and then we can go.
Yes. So the principles for the use of funds from the opioid litigation are 5 high-level guiding process principles. So they don't outline you should spend X amount of dollars on this program or this percentage of your litigation funds on this. What the principles are guidance to get states and localities thinking about how to spend the dollars and what things should be in place before the dollars even come down. So I'm just going to run through them really quickly. There's 5 of them. The first one is spend the money to save lives. So unlike tobacco, we want the opioid litigation dollars to go towards opioid abatement. So making sure the dollars are spent to save lives. The second one is using evidence to guide spending. We have been in this crisis for a while. We have a breadth of research that shows what works and what doesn't work to help people who use drugs. And so using these litigation dollars towards those programs. The third one is investing in youth prevention. So we know how important prevention is to prevent people from starting to use drugs, so that we're not continuing to have more and more people addicted to opioids. So this is a big focus for us. The fourth one is to focus on racial equity. So there are communities that have been differentially impacted by policies and practices in this country. related to drug use. And so with this opportunity for money to invest in programs that can help kind of balance out how folks have been treated for their drug use. And then the fifth one is to develop a fair and transparent process. What we learned from the tobacco settlements is that the money went into the general fund and states spent it how they wanted to. There wasn't a lot of accountability. So we have encouraged states and local governments to create a process and to make it transparent, and have it include people from the community with lived experience, experts who know about drug use and addiction, and throughout the process, the funds are going to be dispersed over 18 years to keep that public and transparent so that there can be these checks and balances. So those are the 5 principles. Yeah.
Those are solid, definitely solid.
We had a lot of help in creating them. So we had folks from across the spectrum, prevention specialists, harm reductionists, people in the recovery community, addiction medicine specialists, kind of everyone that we knew, and we got referred to people, and we know what we can do. And we also know that there's just so many people with so much experience and insight. And so that's kind of the principles have been this collective effort. And they now have been endorsed by over 60 organizations across the country, and they've been nationally recognized. And yeah.
That's excellent. Now, what about, so you created these principles, solid principles that, there's a consensus effort of organizations to follow, but are the 3,000 beneficiaries of the settlements, are they following that?
So I would say some are. It's a lot of entities, right? I think the biggest step is that we've seen states enact implement legislation, creating the fund. That's like the biggest one. The first step is like, are the dollars protected? We've seen states like Maryland, who they were one of the first states to pass a bill creating a fund. They went back this past legislative session and introduced a new bill to create a council, an oversight council and advisory board. So we're seeing the principles pop up in different ways, and states are taking different approaches. And that's kind of why we made the principles so broad and less prescriptive, is because every locality is going to have different needs, and they approach budgeting and politics in a different way. And so keeping it broad, I think, allows the principles to be used in a way that is effective for each locality. So lots of legislative funds, formal agreements. North Carolina has they took a unique approach and created a formal agreement within the counties. So the counties are getting more of the money. And that's what works for them. So it's interesting to see how the principles are being interpreted and implemented across the country.
Now, can the money be used on, for example, all the money be used on one thing? So, for example, can they say all the money, we're going to spend it all on safe consumption sites, which is not quite evidence-based. Does anybody have done that or looking into that?
So, and I'll just preface by saying that the MDL funds haven't been dispersed yet. The first round of funding as of today hasn't gone out yet. So we haven't really seen how the money is going to be spent. There's been a few budgets proposed, but we don't actually know yet how anyone is going to spend the money. I have not seen any examples of proposed budgets where all of the money that's coming down is going to go to a overdose prevention site. I have talked to some localities that are interested in overdose prevention sites, and Principle 2 does outline using evidence to guide the spending. And there's a note in that principle that if there is a promising intervention, that I think it is an appropriate use of the litigation funds to be used towards a pilot or research around a promising practice.
Yeah, that's interesting. I see the whole issue of harm reduction going very broad, and and people say, okay, this is the latest thing, this is what we're going to do, without the science backing it up, and also the science that measures the effectiveness. So, like, for example, the New York site is measuring how much trash they're getting out and how many overdoses, reversals that they're having.
Mm-hmm.
But I don't think that that's the science. I mean, you could collect all those, of course you can have all those needles when everybody's using in that one spot. That doesn't clean up the parks, right, where you're still having needles. It doesn't mean that people are stopping to use everywhere else in the area. And the other measurement that they're using is, well, like, I think they said it in 8 months, they had 157 overdose reversals in a place that's supervised. Well, of course, no one's going to die when there's someone right there giving you naloxone as you're using. But did that even have a dent in saving lives in that community? Or did it even have it worse? Did more people use because just using drugs is being normalized rather than connecting people to treatment? So I fear that someone has an interesting idea, and now that's taken up as science, and even the measurement that they're using, their success, is not really evidence-based. I don't know. That's a loaded question for you, but I just wanted
So I think there's a lot to unpack in that. And, overdose prevention sites have been active across the world for 30 years. And the outcomes that they study are different and complicated. And so a lot of the research does look at the impact of things like overdose deaths that were prevented, the transmission rates of diseases like HIV or hepatitis C, the quality of life for people who use drugs, referrals to treatment, and then like you mentioned, crime and public nuisance. So those are the things that are typically studied or researched around overdose prevention centers. And the research that I've read, like you mentioned, there's been no fatal overdoses reported on site at an overdose prevention site, which I think is compelling if we're thinking about the root cause of, or the root of harm reduction is to keep people alive who are using drugs. It's hard to say whether those people would have overdosed elsewhere, but there are people who are using drugs, so they are at risk of overdose.
Or that they would be reversed elsewhere, because that's what I see as an emergency physician, right? I see patients who come into the emergency department, they're there for an overdose. I'll ask them, well, how many times have you overdosed? 9 times, right? Mm-hmm. They didn't go to a safe consumption site. They were in a location. You don't have to go. It seems like it's counter the principle of meet people where you are. Instead of saying meet people where they are, which would be have naloxone everywhere there's possible drug use, you're saying, come here, use with me. It's the opposite of meet people where you are. You're telling people to come to where you want them to be.
Yeah. So I mean, as a person who doesn't use drugs, it's hard for me to speak to their experience. But I can tell you like some of the things I've heard. And I think especially in the pandemic where people were feeling isolated, people may use alone and may not have someone around to revive them. And so maybe the overdose prevention center is a safe place to go. Or maybe people are using in abandoned buildings or on street corners, and maybe they're using together. But what overdose prevention centers also offer, other than just, supervised staff to revive them, is also, drug checking or safe supplies. So it's kind of it's a holistic approach that offers access to a lot of these things that are sometimes hard to come by. And I know particularly people who are unhoused, that's a hard population to access. And as someone who did outreach, we were able to meet those people where they were, but not everyone we could find. We had zones that we went to. And so having a designated space where these people can maybe use drugs, but maybe also, pick up safe supplies or get treatment from a nurse for an abscess. Having access to all of these services in one place is also a benefit of these centers.
how does that, okay, so it's really hard for me as an emergency physician to see money, because we're talking about money going to that. When I see patients who have an infinite number of places where they can use drugs, but yet when I have patients, and this is every day, multiple people who want to get sober, there's no place for them. So I say, how are we spending money to build places for people to use drugs when there are lots of places where they're using drugs? We could make those places safer, right? All the shelters, all the sober living facilities, we can install, naloxone and make all those places safer. But yet we have no places to go when it's just heartbreaking. When I have patients who have overdosed, they're almost dead and there's no place for me to send them.
Yeah,
I could just say, instead I'd say, we'll use over here. It just doesn't make sense.
I think it's part of this holistic picture, right? And I think as personally someone who sees the benefit of overdose prevention sites, I think there's also an important focus on treating all or having access to services across the spectrum. So people who are using and are ready for treatment, making sure that they have access to treatment, and that's a piece as well.
But they don't.
And no, I'm hearing you, and I agree. I think more treatment is necessary, but not everyone is ready for treatment. And so these harm reduction services ensure that people stay alive long enough to get to that place where they want treatment. And yes, there is also a need for more treatment and a variety of treatment options. And that's also a great use of opioid settlement funds. And one of the approved uses is, expanding access to MOUD, warm handoff programs, peer support. All of those are pieces to this puzzle. And all of those together is going to be what investment in all of those areas is going to be how we reverse this crisis. It's not going to be singularly any of these things. We've got to think about it as a whole picture.
I agree with you. I agree with, of course, saving lives from people who are using. I guess don't agree with that methodology. It's not evidence-based and it's spending a lot of money. It's cost intensive where there's such a big need on the other end. And I would rather promote increased syringe exchange, right? That's evidence-based, and you can add more, connection to treatment, and I mean that's science, that's evidence-based.
I think communities are going to have to see what works for them, and I think in this country specifically, like overdose prevention sites are not common, right? We have 2 in operation, and then 2 others, like maybe in Rhode Island and Philadelphia. So it's not something that I think is a popular opinion. And if funds can be used to support existing harm reduction programs and existing treatment programs and expanding those, I think that's a great investment as well.
I agree with you, but the problem that I see is just a natural American problem that I see with a lot of things is you have 2 sites and then now that is the standard of care. That's the gold standard, even though it's pilot project and the data's not even out and we haven't even measured the right things. I'm in California. They're like, okay, we got to get one of those. We got to make that all over the place, San Francisco, LA, and missing the big picture that this is not going to save total lives. It may help some people on one small cohort. And at the same time, if dollars are spent there, they're missing the big picture in what prevents deaths in the first place. Right. And you're right. It takes a holistic approach. And we've talked a lot about that. Tell us about other key initiatives from the opioid initiative that you're excited about that are being worked on.
Yeah. So the Bloomberg Overdose Prevention Initiative, we work in 7 states, primarily do a little bit of work elsewhere, but primarily in 7 states.
Which are the 7?
The states are, let me go down the line, Pennsylvania and Michigan, Wisconsin, New Mexico, Kentucky, North Carolina, New Jersey. That's 7. And there's been some really cool initiatives that have come out of our work there and that our research team has gotten to look at. New Jersey had an initiative where they expanded MOUD access in carceral settings. So that was a really cool initiative to be part of. They also, during the pandemic, had a prisoner release initiative where they reduced their prison population by releasing folks with lesser nonviolent crimes. And so we are in process of studying kind of the impact of that, particularly the folks that in that use drugs. So that's been cool to see. We did an evaluation of a BUP initiation on ambulances in
buprenorphine.
Yeah. So we got to work on a pretty cool project in Pennsylvania working with buprenorphine equipped ambulances. So as you were mentioning about meeting people where they were or where they are, if someone has experienced an overdose and first responders come out to revive them or to treat them following their overdose, having a prescription for buprenorphine on the ambulance allows them to have a discussion with the individual, ask them if they're interested in treatment. And if they are, they have that treatment right there. They don't have to try to find a provider later. They don't get a referral. They just get treatment right away, which is very, very cool.
That is cool. And actually, we had them on this podcast. So if people are interested, they can listen to the episode with Martha Waller and Tara Tucker talk about that experience. There are a lot of challenges, too. Mm-hmm. It's not, again, the problem is people think of that's a great idea. And it's like, okay, let's everybody do it. But you really have to understand it and understand the pitfalls because it was not easy. And they had a lot of motivation to get it done. So to translate that to all the communities would be challenging.
And that's one of the cool parts of the research that we do is a lot of times we do mixed method studies, meaning so we look at outcome data, but we also can do qualitative interviews with the folks that are implementing these interventions and learn about what some barriers were, what was really helpful, what would you want someone else who is doing this to know? And then we can share that wealth of knowledge with other people who might be interested in that kind of program. So rather than all these programs starting from scratch, we can share what the folks in Pennsylvania learned or in the New Jersey MOUD expansion in jails, like what did they learn and how can that help other programs who are thinking about doing similar things?
Has there been things that you learned that, okay, this doesn't work? Because sometimes you learn the best also from things that don't work
out. That's a really good question. I think there are things that have been harder and maybe less, the outcomes that we thought were different. And I think that happens a lot in research as you go in thinking, okay, this is going to have a direct impact on this thing. But sometimes that's not what you find. So an example of that is we worked with a hospital system who was implementing a learning action network in their hospital system. So connecting the different hospitals around MOUD. And it was difficult and it was during the pandemic. So hospital staff were stretched really thin and had different priorities. And that was something that we weren't obviously expecting COVID to happen. But I think we learned a lot. And sometimes failures are the way that you learn. And so expecting that and we still learned things from it, just not what we thought.
So this was a program where you tried to get hospitals to implement MOUD, which is medications for opiate use disorder.
Yep. And this learning action network was like, peer learning, right? So the hospitals, there are rural hospitals and there's urban hospitals and they have different resources. And, maybe some were able to bring in peer counselors and, what was that experience? So allowing them an opportunity to share with one another about the things that were happening and the things that they were learning in this implementation process.
That's interesting. And do you have like a favorite project or what would you really encourage communities to do from your experience?
A favorite project. I personally I think because of my background in working directly with people who use drugs, I think the projects I've liked most are the ones where we have an opportunity to talk to the clients of these programs or to individuals who use drugs and to find out, what they think, what their experiences have been, because as researchers, as policymakers, we might have ideas about what works, or, we're like, oh, this sounds like a great idea. But for the people who are actually going to use the service or the program, I think it's great to have insights there and to hear from them about what works, what the barriers were from their perspective. So those are my favorite projects.
Yeah. And what was one of the top solutions for them that they said worked for them?
Yeah, so we did a project during COVID. We talked to folks who use drugs to find out kind of how the pandemic impacted their drug use and their ability to access services. And I think we heard a lot about how telehealth was really helpful, and how when people were isolating at home, social distancing, they weren't able to access their programs or go to meetings the way that they used to, and to hear about how the programs adapted to meet the needs of their clients were really cool, and how well that worked for clients. And I think it's just always really awesome to hear about the ingenuity of programs and the resiliency of people.
That is true. But that's surprising to me, because I guess my clientele is different, because you would need to have a phone.
Yeah. Different populations, and definitely access to technology, depending on who the person is, income level and housing security is a big factor in that. And it's a struggle for a lot of people. And, telehealth is one option, but there were also other really cool ways that programs found their way to still deliver services. So we heard about folks who, would go to an outreach center, or traditionally would go, to a syringe service program. And during the pandemic, they couldn't go. And so the programs were delivering supplies to them, which I thought was an awesome way to overcome that obstacle.
Yeah, I mean, I guess that's actually a beautiful thing that we see from the pandemic, is different innovations and ways of continuing your job, and not just in substance use disorder, but in the world at large. Mm-hmm. And some of these creative solutions make us overall better and will sustain even after the pandemic, right?
Yep.
Like
and I
think doing a Zoom podcast,
exactly. Yeah.
So that's really nice. So what if people are listening and they want to know, $32 billion, is my community going to do something? Is my state, is there a way for people to find out if there are funds coming their way for issue of drugs?
Yeah. So folks, there's lots of resources online. I would check your state attorneys general's website to see if there's, a press release, or some states have their own dedicated website now. Florida has one. North Carolina has one. There's also two websites that are tracking this. So opioidsettlementtracker.com and nationalopioidsettlement.com, I think is what it's called. And you can go and check those out and click your state, and then find out if your county or city was also part of the settlement. So in that MDL, states and counties, or states signed on and then tried to recruit the counties to also sign on to the settlement as well. So some did, some didn't. So finding out kind of which entities did, you can use those two websites.
That's great. And Sara, you'll give us that information, so I'll put that in the show notes so people can refer to that.
Yep.
And last big loaded question for you. Ready?
Yeah.
Since we've had such a interesting conversation. But big tobacco, lies about harms, saying that it's healthy, and then big time dollars in lawsuits. And then big pharma saying, opioid prescriptions, nobody gets addicted. There were some lies and now some lawsuits. What do you think we're going to be seeing with big marijuana, now with all the various health claims and some lies and future dollars and lawsuits?
Yeah,
that's kind of my prediction.
Yeah, I will preface by saying I'm not a lawyer and I'm also not a cannabis researcher, but I think that the legal system in this country is meant for checks and balances, right? And to hold entities that are in violation of the rights of people, to hold them accountable. So when powerful corporations, whether that's big tobacco, big pharma, big cannabis, if they put the health and well-being of people at risk for their profits, and that can be misleading health information, different things, right, that we've seen in these two lawsuits. If that happens, I think it is completely within reason to assume that this could happen again. So that's
well said, very well said, and I just kind of threw that at you. And I agree. And the question is, because you're a researcher, you're looking at this, you're looking at history, tobacco, you're looking at current events, opioids, and future, because we could see this coming up with cannabis. Is this even a deterrent? Are these lawsuits a public health deterrent, or is it actually a good business model? We're just going to milk it for as many billions as we can, and we'll get sued eventually and we'll pay it off. But guess what? We made a lot of money in the meantime.
And I mean, that's still, that's a great question, because what we're seeing with these opioid lawsuits is like $32 billion seems like a lot of money to me. But in the grand scheme of what these opioid companies made, drop in the bucket, right? And the cost to states, for the health costs and loss of productivity and all of these other things, $32 billion also is a drop in the bucket. So, will it impact other big corporations, or, is it, like you said, just a part of the business? I think that comes down to advocacy, and lawsuits are one part of that. But I think community advocacy and information around these different public health crises is going to be an important piece of that. We have collective power and voice in saying what we expect from corporations, and how they treat us as consumers.
Right. That's good. And I hope that happens. You're a big part of that, Sara, because you bring the data and the science, and we hopefully use that kind of information in making these decisions and holding people accountable and for advocacy. So thank you for doing that. I want to thank Michelle Leopold for her questions and for her advocacy. She advocates on the harms of marijuana because her son overdosed on fentanyl, but his life and journey into drugs started with cannabis, as most people. If I talk to every single person who I see in the emergency department who has an overdose, I ask them about their journey to drugs, and 100% of them started with cannabis at a young age. So I definitely see that. And so thank you, Michelle, for speaking out, and may the memory, and I know the memory of Trevor will be a blessing because of the work that you're doing. And Sara, thank you so much. I mean, you have a great job working with a population that you like and have feeling for. I can tell you're passionate about this work, as many people are who work in the issue of substance use disorder, and your research and mission is so important. So I thank you for that and wish you the best with it.
Thank you, and thank you for all you do.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support from our sponsor. A sincere and warm thank you to Isaac, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isaac1.org, IASIC1.org, to view their medical library translated for public understanding, listen to their speaker series, and follow the science. Our producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.